very open talk. And we've tried to shorten it a little bit. Okay. Yeah, I'll be in charge. Okay. Thank you for our amazing introduction. And thank you guys all for letting us be here and talk about it. It's been such an experience, I will say, this entire project. So we're really excited to be here. Kelly introduced us, so
here we go. So our process at Seattle Children's is we kind of separate out our therapy into phase 1, which is the pre-OAP phase. It takes place in the NICU. Phase 2, which is our OAP adjustment phase, and this is going on between NICU and our acute care medical unit. And then phase 3, outpatient, is the maintenance phase, and this is happening mostly outpatient and through our clinics. You've all seen this, so we'll skip over that. So phase 1, Tracy's going to start and talk about development during the pre-OAP phase.
So just quickly, and to change topics a little bit, why do we need to pay attention to this? This is very well known in the neonatal realm, that early experience alters brain structure and function. This is very well researched, and if you want more information, you can look up the work of Dr. Heidelise Alves through the NIDCAP Foundation. We have to remember, if you look on the schematic here, that we are introducing this therapy right at the time of active myelination, synaptogenesis, apoptosis, which generally translates to neurons that fire together or wire together. And we are introducing an intervention at this critical period of development. We've talked a lot about form follows function and individualized approach, but this is really the foundation for why I would encourage everybody to involve their occupational physical therapist, your developmental specialists, along this journey, so that you can infuse this approach throughout the whole process. We, on our team, our very first task is to help stabilize the infant ideally in prone positioning. We work very closely with mainly the bedside NICU nurses, but the neonatologists and the craniofacial team. I will just highlight that I've noticed a phenomenon with these infants where some of them can have pretty severe cervical hyperextension right from the beginning, and that can get worse. My theory is that it has to do with airway stress. And so sometimes what we think is optimal with prone ends up being very difficult to achieve. And we have to really, really problem solve with our different tools. This is one of my favorites. I don't know if they're using in Europe, called the Z-Flow. But this tube system has proved brilliant you can use it to prone the baby to provide a ventral surface. And then you can also use it to customize for side lying. And then when the device comes, you can customize out, so the baby isn't going to bump the device by moving their
So the baby is placed in between these two.
Yes, and it can be circumferential. It's quite long and it's very moldable. It's essentially the opposite of like a Tempur-Pedic mattress, where you put your hand in and pull it out and it fills up. However you contour this, it stays that way. It was initially invented for burn patients, so there's very good pressure relief, and the company has those numbers if anybody needs them. We use the synactive theory of development. Again, this is the work of Dr. Heidelise Alves and NIDCAP. Really what this is saying is this is a dynamic framework. It's very hard to do any kind of standardized neuroassessment on these infants with the level of stress, at least that our infants have. And what this does is that it really allows us to use a dynamic framework to get to know the infant and help us understand the impact of the UAO on all of these other systems. It also gives us a platform to bring the parents along with us, so that we help the parents understand their infant from the very beginning. And then we'll switch over as we really try to work together to support this phase.
So when we think about the feeding assessment for a pre-OAP infant, I will just say that all our infants come to us very differently. Some are transferred directly from their birthing hospital quite immediately. Others have been out in the community feeding for 6 to 8 weeks on end and then are getting admitted. So since we're not a birthing hospital, we do have quite a wide range of our patient population. And so when they are admitted, we do initiate NG tube feeding for nutrition and then assess any current feeding if there is any at that time. We really focus our assessment on their secretion management. Do they have suctioning needs? How does that change with oral stimulation and their body positioning? And also, how does that relate to their work of breathing? So we're focused a lot on their respiratory swallow interface, both with their secretions and with milk if they're ready for that, as well as how that relates to any airway obstruction. So thinking about how frequent, what their state is like. At this phase, we might do some non-nutritive and pre-feeding activities or even some cautious oral feeding. It really depends on their level of respiratory support. If they're over 2 liters of high flow nasal cannula, then we do keep it quite conservative. But we'll work on pacifier drops in milk, focusing on skin-to-skin care, supporting the lactating parent to provide that breast milk if that's within their goals, and just really focusing on fostering those positive oral experiences during these critical periods of development, especially when that can be hard if they've come to us with already a lot of negative oral experiences ingrained in their repertoire. So sometimes it's breaking down a lot of those things. We're also really focused on the oral exam and stimulation, kind of what Petra was talking about, having a good understanding of what their tongue position is like at baseline, and then also how that changes throughout treatment. And along the whole way, we're partnering with their caregivers and talking about what feeding might be like with the OAP progression.
So these patients, these pre-OAP patients, are being taken care of in our NICU. And the NICU nurses play a very special role because I think one thing that is a little tricky about healthcare and just social systems in America is that we don't have many. And so lots of times parents can't be at the bedside during this. And so they'll be working or taking care of other children or coming from a long distance. And so the NICU nurses are like the fierce advocates for these patients. They make sure that care is being delivered through the neuroprotective model, and they also help support the feeding plan as well. So they really partner with the feeding therapist and the developmental therapist. They're also supporting the parents to be the primary caregivers when the parents are able to be at the bedside and supporting that infant parent diet.
Now, phase 2, the OAP adjustment and initial placement period.
This is just a reminder that this is not a one and done assessment. It's really an assessment and treatment that is dynamic and ongoing. We are partnering again with the parents all the way through this phase. One thing that struck me yesterday, that mom at the end, when she said she was struggling to bond with her infant, I would never, ever want to hear that from a family, and a huge part of our role is, I think, to make sure that the families, first and foremost, feel like the parent from the very beginning, whatever they can do. And it's really surprising how much of the care they can do for these infants when you give them the support to do that. So this is just an example of things that would fall under neuroprotection and neuropromotion. Some of this has been talked about today, which was really nice to hear because I didn't hear any of it during the main conference. But making sure you have 2-person cares. I don't know if you noticed the hands of the folks on the videos where they were providing containment and hand hugs. We often have parents that don't want to do that, but they want to be present. And so I'll often explain to them who is doing what and how their baby is being supported while they're waiting to receive the infant. You can use, I think Connie alluded to sucrose. You can also use express breast milk to help calm the baby as a pain relief right prior to the procedure. If the baby tends to be very strong with their arching, because you'll notice a lot if you pay attention that when infants start to hyperextend through their C-spine, it often goes through the rest of their spine, and it can impact getting them in the proper position. So you can use a double swaddle where you're using the direction of the swaddle opposite, and what you want to do is create flexion in midline to help block the rest of extension through the body, and it will help ease keeping their C-spine in a more neutral position. And then just a note down here, of course, we encourage skin to skin. We don't force skin to skin, but right after the procedure, you can get the baby right on the mom if she's willing. If she can't, I have found this clutch hold, it's sometimes called a football hold, from the lactation world, to be really effective, where you tuck the baby right into the mom or dad, their arm, so that they can settle out after the procedure immediately with the parent. And then you're reinforcing that the parent is providing the nurturing experience. And then just quickly, we will move from touch hold to needle touch and massage, and that is only for the parents or caregivers. That is not for anybody else to do. These strategies here, the myofascial trigger point and gentle stretching, I would really want to highlight that those need to be done after C-spine precautions are cleared. Some of our infants are so hyperextended that you need to be really cautious there, and just check with your teams and make sure before you start any kind of release to manipulate the chin to a more neutral position. Okay, just quickly, we keep the infant sidelined 48 hours after initial placement, and we progress clinically. I think what's really fun about our team is that we really work together and we're communicating constantly. So if I have been able to achieve certain developmental positions or milestones or activities and something's been adjusted and then I can freely give that feedback to the team that whatever adjustment was made, or maybe it's time for an approaching adjustment sooner than we thought because there's a change in function. And then just, of course, a note that back to sleep is always our goal. I have found that these babies are used to a lot of swaddling, and the sleep sacks can be really helpful to bridge the gap if they're not comfortable going straight back to sleep. That is allowed in the US at any rate to use a sleep sack, and it can help train with sleep training. And then this is just a sample. We strive to create a sample like playbook, essentially, sample activities for each infant. And so this is just showing some really gentle trigger point release because this baby was still quite stuck into hyperextension. And then once we get the release, we move into using her visual system to drive her capital flexors. And then we're doing it again in the NFOS position. Ideally, these are activities that the families are trained on and practice, and they get their book so they remember what to do right before discharge and ready for discharge. And then my biggest thing is prone. These infants need to do prone, and they need to do prone with optimal alignment so that you can again engage the anterior neck muscles, chest muscles, and get ready for proper weight bearing because they will overstretch their capital flexors. That can negatively impact swallowing, vision, all kinds of things in development. So this is really
So when we think about feeding across the OAP adjustment period, it really starts following the initial OAP placement. And we do hold the pacifier in bottle for 24 to 48 hours after initial OAP delivery, and 30 minutes after daily OAP replacement, because we have found that use of these devices within those time ranges can lead to increased oral sores or increased secretions. Because we do expect secretions to increase, but what I'm really there for is to assess how that's changing based off of position and if there is a new adjustment. So like Tracy said, our team is super open to if I'm noticing, I'm noticing so many more secretions, I'm wondering if we need to take a look and see if we need to adjust the plate anymore. I do look for the orthodontic and craniofacial approval to restart the pacifier after initial OAP placement, just to make sure, because if there are already oral sores that are getting bothered, then we might hold the pacifier for even longer than that. We found that the best pacifiers are some of the smaller premature ones, and I have some that I can show you guys today. So these are more ones that we typically use with our premature infants. But because there's not as much real estate in the oral cavity after that initial OAP placement, we found that these smaller ones can be helpful, and even like the flatter, the better. So I have two here that are helpful. And what we'll do, because sometimes those external wires take up a lot of space, and there's not enough space for the pacifier to become flush with the mouth, is that we'll actually cut the external portion of the pacifier so that it fits nicely flush in line with the infant's face. And so it can be helpful for those pacifiers to not have to have a flexible outer exterior instead of a hard one for that. The other thing that has been somewhat helpful, and I will say we will add like tastes of milk or tastes of sucrose, things like that to these pacifiers. The other thing is if the infant is struggling with their secretions, especially after initial OAP placement, which is quite common, we will utilize what's called a binky to suction. And what this is basically, it's basically a pacifier. I'll show you, this one's a little bit different than that, but it's basically a pacifier that has tubing hooked up to it. Here I have two different custom made ones. I custom make all of these. And so what you do is you hook it up directly to the wall suction. And so the infant can actually engage and like learn how to use their tongue and start to engage in those non-nutritive skills, but without that increased secretion burden that typically happens because the suctioning is taking it away in real time. However, this isn't an end goal. So the goal would be to wean that suction aspect of it as quickly as you can because you want that infant to start to learn how to manage their secretions on their own. So when we think about the first oral feeding readiness after the OAP placement, what we're looking for our general criteria, and like everyone has said, everything is highly individualized, so not every infant is going to follow this pathway. This has just kind of been our experience so far, is that we want them to be on room air or up to 2 liters of high flow nasal cannula, demonstrating adequate secretion management, state regulation, as well as the tolerance of those non-nutritive and pre-feeding activities on the last page. And we do look for their total CO2 to be downtrending or under 30 generally. So where do we start? We do typically start with small volumes, so like 5 to 15 milliliters. Again, it really just depends on the infant. And kind of the inverse of the binky to suction is the binky trainer. So what you can do is actually use the NG tubing and thread it through the pacifier and then attach a syringe full of milk to it. And this is a way that the infant can actually start to learn how to suck on it while you provide just a little bit of milk in line with their pattern. So it's kind of like an in-between, I feel like, of what Petra is talking about. What I typically do for this is with one of our bigger pacifiers. So I actually typically make this with one of the smaller pacifiers too, whichever one the infant prefers the most. So often we'll go to this. Another option, though, is that we will go to the Dr. Brown bottle, and I'll talk more about the Dr. Brown's bottle generally on the next slide. But we do use the smallest nipple, so the ultra preemie nipple, the one with the slowest flow rate, just so that that infant can start to relearn their swallowing in a very cautious but kind of structured way. And what's nice about this is that it provides that one-way valve, and so the infant doesn't need to engage in that negative pressure suction to extract, and they're getting quite a small amount of milk. And I'll talk more about this. Is just about the Dr. Brown specialty feeder. I just wanted to give more information. This isn't like a plug that you need to use this one. I'm not a Dr. Brown's rep or anything. This is just the type of one that we do typically use. And the reason that I personally like it so much is because it is an infant-driven method. So that means that the feeder doesn't provide any squeeze assist or anything like that. I can put water in that too to like show you guys how to do it. But and what's different is that these are also the bottles that we stock in our hospital, but the only thing that's really different about this from like a typical bottle that for a non-cleft infant is just this little blue valve, which is quite helpful. And the other thing that's great about this is that we have a lot of flow rate options. So we have the ultra preemie, transition, and then all the way 1 through 4 after that. And so we're really able to adjust the flow rate based off of what the infant needs in that moment and help them progress over time. And so when we think about that progression, what we're looking for across this kind of spectrum is, I will say, we see these infants quite frequently inpatient because things can change so quickly and they kind of need some close eyes on them. And I'm constantly assessing changes with OAP modification and with growth, changes in their secretions, their swallow sounds, any signs or symptoms of aspiration, stridor, stuttor, gagging, coughing. What does their tongue position look like? Are they able to bring it more forward, or are they still keeping it very retracted? What are their oral feeding skills like in their endurance? What about reflux? And we do typically do more of an incremental bottle feeding progression, especially at this stage, because all of our infants will discharge with an NG tube. We find that can be most supportive for their overall positive oral feeding progression as well as their growth long term.
So the nursing phase, or the nursing considerations for the OAP adjustment phase, this is still going to be starting in the NICU, but then these children will be transferring to the medical unit. The nurse is still really involved in collaborating with Lucy and Tracy and really promoting the feeding plan that Lucy has set up, reinforcing that with parents, and again, with just ensuring that we're considering neurodevelopmental and neuroprotective care and everything that we're doing. During the time immediately after the plate is placed, the nurse is monitoring the child's respiratory status, providing frequent oral suction as indicated. If they're not using the binky to suction, the nurses will manage the NG feeds and also encourage those positive oral experiences like the pacifier dips. And really, again, we try to support the parents to be the primary caregivers, and we're learning, I think, a lot that this looks like starting education really early, even though sometimes parents maybe aren't ready. It's really important to like start involving them in the care and talking with them about everything. One area that we have kind of identified as an opportunity for improvement is the transition from the NICU to our acute care medical floor. As Dr. Evans and Dr. Scheller mentioned yesterday, we have like well over 100 acute care nurses, lots of travelers, lots of float nurses. And so often when these kids are on the acute care unit, they're seen by a nurse or cared for by a nurse that has never seen the OAP before. However, Dr. Scheller and Marilena, they come to the bedside and do the changes every day until the parents are all trained up on doing this. So the nurses aren't doing the OAP changes at the bedside. But one thing that we are hoping to do is make a beautiful video like yours that we can have available for our nurses, so that if a nurse has come to take care of this patient and has never seen the OAP, they can quickly just open and watch a video demonstrating how to provide the care.
You guys have a hospital like designated to specific units?
We sure do. This is all still very new to them too. So the majority of the education comes now from our craniofacial team. But Dr. Evans and I are working with the clinical nurse specialist on the medical unit to create some more of the educational materials. That's how we came up with the idea to do the video. Yeah.
Does that mean a potential competency checklist for teaching the families is in the works?
I think Dr. Scheller already has that. She is, Dr. Scheller and Marilena are the amazing people that train the parents, and they come to the bedside every day. They teach the parents how to do the therapy, and then they check in frequently with them. And so I'll let her speak to that. Do you have a competency?
We do.
Yeah.
And in our notes that we make every day, we document the progression, the date that that skill was started and mastered by mom and by dad or another caregiver.
Mm-hmm.
And so it's there, kind of the list that they move through. First thing is taking it out.
Yes. Yes.
And we also teach them all the taping and all this stuff.
Yeah, we are still definitely like in the early phases of this. And so we're all the time, like we're finding and creating new materials for the staff at the hospital.
I might email about the competency checklist if you're willing to share.
Okay,
thank you.
We'll share.
We're gonna move on to phase 3, the OAP maintenance phase. So Tracy can start at that.
Just very quickly, things are still evolving at this point. My role, the role of my team, is mainly hospital-based. We don't yet have any kind of high-risk pathway for these infants. That's something I was curious. I don't know if there's any other therapists here or online. We've done 2 assessments, one at 2 months, one at 3 months in the clinic after discharge. But mainly that has been to bridge to what we call ESIT, which is early support for infant and toddlers, or early intervention. It has different names in different places. It's a home-based 0 to 3 program in the States. And then once we feel like those that program, those therapists are up and running and ready to go, we stop. But we're still kind of thinking about whether or not these babies should be placed on a high-risk pathway like a HIV or something along those lines.
So when we think about bottle feeding progression in the OAP maintenance phase, this really spans inpatient and outpatient services. My position is unique right now that I also span inpatient and outpatient, so I'm able to follow these kids for continuity. And so I will say we do most of our bottle feeding progression in the outpatient setting when we think about like tube weaning. And so we'll make incremental increases in the infant's flow rate, volume, frequency of oral feeding, maybe time limit. And then along all of that continuum, we'll monitor for signs and symptoms of aspiration. What is their respiratory health looking like? What is their growth looking like? And also just monitoring what is the baby telling us in that moment. And I will see these infants every 2 to 4 weeks when they come in for their OAP adjustments with Dr. Scheller and our orthodontic team. And so we'll work specifically on positioning, pacing, if we want to try different bottles. All of this is highly individualized, obviously. So we don't have like a set protocol for that. It's more based off of, you know, what you're seeing in the moment and what's going on with that family in that time. I do a lot of education, not only with the caregivers, but also the medical team, not just within the hospital and the inpatient unit, but also outside of the hospital. So our community workers, they are not very familiar with this and definitely get very confused. And so I have a lot of conversations with them about what this is and what it looks like. I am so lucky to have support of our amazing dietitians and craniofacial pediatricians, as well as the craniofacial nurses during all of these visits. And that really helps provide that multidisciplinary care to either focus on that NG tube weaning or also bridge that conversation about transitioning to a G tube, depending on what's going on for that infant. Because I will say our approach is very much quality of oral feeding over quantity of oral feeding. We want to provide opportunities for very, very good practice. This is really rooted in the principles of motor learning, which is well established in the literature. And it is especially important during this critical period of neurodevelopment, like Tracy was saying. This is such an important time for those neural pathways to be forming. And I want all of their swallowing pathways to be associated with really safe swallowing as well as really positive experiences, especially during this specific transition around 3 months of age where that swallowing and sucking reflex transitions to more of a volitional action. That is a specific, kind of vulnerable time for that infant. And that's why we do really focus on an infant guided feeding model. So I'm focused on reading their cues, seeing how they respond to different therapeutic techniques, and then guiding the treatment plan from there. This has really helped to decrease any of their stress cues during feeding, such as, coughing, turning away, sounding wet or congested, stridor, sturder. It also helps them build that endurance for feeding, as well as decreasing the risk for refusal and aversion later on, which can sometimes happen if we push infants a little too far early on. And the other thing that I just like to think about, in relation to this population is the high risk for aspiration and the negative sequela that can come to that. I think that with this population, what we've seen is that there's definitely that risk for aspiration just with their breathing interface, because we do have, difficulties with breathing and airway obstruction. But then we've also found that some of our infants also have like a primary dysphagia or primary swallowing dysfunction that still persists even after their airway has been stabilized. The other thing I just wanted to talk about too is that we do start pureed foods when developmentally appropriate. And if the infant still has the OAP in place, I mainly just thought these pictures were really cute too. Nothing too formal here, honestly. The biggest thing with the OAP is just to check the fit before and after, because infants are very much more mobile by then, and so they might be messing with their face, or some pureed food might get under it. I will say I haven't done like actual solid foods with an infant undergoing OAP treatment, but we have started some nice tastes of purees, and it's great to get those novel experiences early on. Or give us a Lindsey.
So in the OAP maintenance phase, this is where we are supporting parents as they transition back into the home and into the community. And what we found is, like with feeding and development, that's a very individualized experience for everyone. So some of our parents are a little more savvy and confident and they don't need as much support. And some of our parents are absolutely terrified to leave the hospital after 3 months. And so that's kind of where I come in to bridge the gap and really like support them as much as I can. We will help them navigate like setting up home care. If they're struggling with that, we'll triage tube feeding issues. We monitor their weight and growth. We have frequent nursing check-ins. So like if Lucy isn't able to see someone when they come in for an OAP adjustment, then I or my other nursing colleagues will see them just to make sure that we can really reinforce the quality over quantity and the positive, kind of all the positive feeding and developmental work that we've done while they're inpatient. We just really want to help parents carry that over when they go home, and then continuing to try to encourage them to enroll in early intervention services. And we also coordinate these frequent multidisciplinary team visits. So when our kiddos go home, right now they often come back at least in the beginning every week to 2 weeks. And when they're coming back for those visits, they're seeing orthodontics, nursing, and pediatrics and or speech. And so it's a lot to kind of coordinate into a nice time for the family where they don't have to come to the hospital 3 times in 1 week. So I really think, again, as of our role in this phase of therapy as being like the parents' cheerleader and support person and liaison. And I really think that part of this is because in the United States, we have a unique challenge that healthcare like this can be very hard to access, and there can be many barriers for families to accessing this care. And so we really try to strive to deliver it equitably. And so the nursing team pairs really closely with social work to try to connect family with the resources they might need in the community, whether that's a public health nurse, early intervention services. We do have cultural navigators at our hospital. And I can't stress enough that the delivery of this care in America is very different. And so it's just something that we have to be really thoughtful about. And I think our team is does a great job of that.
So I did want to go over just a little case example. It is more focused on feeding right now. Because one thing that I feel like we've been really trying to evolve and focus on is swallow pathophysiology and swallow safety with these infants, especially because obviously I'm a speech pathologist, so I is not just the oral phase, but it's the pharyngeal and esophageal phases as well that are quite important. Oh no. So I'm just going to go over a little case example about a patient who was fully orally feeding using the Dr. Brown specialty feeding system with the level 2 nipple. Since he was born at an outside hospital and was discharged home. And he presented to us for his initial outpatient evaluation. And that's how he was feeding. He was doing okay. You know, he's kind of on the line. His airway obstruction was on the line, as well as his feeding at that time. But over the first few weeks of life, we started to see a decline in his volume intake, his endurance. He was having prolonged feeding times and increased signs of aspiration. And this was very much in line with his worsening tongue-based airway obstruction due to his Rovian sequence. And so he was then admitted for airway workup and OAP. And an NG tube was placed given the inability to meet nutritional demands at that time because his growth was falling off. And we decided for him it would be beneficial to undergo a video fluoroscopic swallow study, which is like an X-ray movie of swallowing. I don't know how familiar everyone is with that, but and I'll show you it right now. Because this is his pre-OAP swallow study. Let's see if I can let it go one more time. Oh, you can't see it. I'm just going to use my finger because I don't know how to. Can I get this to start over? Sorry, I just was using it. There you go. So here you can see them swallowing. This is the NG tube. We want all of the liquid to go down into the esophagus, and we don't want any of it to go towards the trachea. And so here you can see in between swallows, he actually has an instance of microaspiration right there, where the liquid is going into the laryngeal vestibular and ultimately down into the trachea. And this certainly seemed more of that breathing interface because you can see it on that residue in between swallows. And so this infant ended up undergoing OAP treatment and as well as feeding therapy, kind of to the protocol we were saying. And, so after, now he's in phase 3 of our OAP treatment. So he's in the maintenance phase. This is after about 3 to 4 months of OAP and feeding therapy. And he was just about ready to graduate from his OAP. And so now I'm going to show you the swallow study with the OAP in place. I'm going to try to be better about, I'm just going to show you the anatomy first, I think, because it goes over quite quickly. So these are the external wires there. And then this is going to be the pharyngeal spur. The black liquid, that's barium. That's what we use so it shows up. And then this is the back of the pharyngeal wall. And that's the NG tube coming all the way down. That's where we want all the liquid to go. Here is where the larynx is. Perfect. And so you can see we're not getting that typical tongue-based retraction, obviously, because the OAP is there, but it's really great to see how much the pharyngeal wall compensates to make that pharyngeal stripping motion and to actually move the bolus or the ball of liquid down. And we can see this infant is able to protect their airway quite nicely throughout this process. And just so you know, this is the exact same bottle and nipple that was used in the previous one where we did see aspiration. So you can kind of see that. I think it's also cool because you get this nice lateral view of the OAP, which is quite interesting and something that we hadn't quite gotten before we did that study. And so this is the exact same time point. So this is within the exact same study. We just took out the OAP during it. And so this is the exact same everything except minus the OAP. And you can see, I feel like the biggest difference is that the infant's actually struggling a little bit with swallowing without the OAP in place. They're like, oh, I don't quite know how to do this anymore. You can see their rhythm is not as smooth. He's kind of trying to figure out, oh, when I extract some of the liquid, some of it goes up into the nasal cavity more because the OAP isn't there. But he gets the hang of it and keeps going, and he's still able to protect his airway. And he's doing a wonderful job. We just learned from this that it's great to introduce a few feedings without the OAP in place before you're ready for graduation. And so when we think about how the OAP impacts the swallow pathophysiology, my suspicion is that it likely evolves as the airway does throughout their development. And like I said, it provides a really interesting lateral view of the OAP, especially during function. And we did see improvement, but we have lots more to learn. And what we found, these are just our quick oral feeding outcomes. And so pre-OAP, you can see most of our kids were 100% tube fed and only partial oral feeding. And then post-OAP, we have 6 patients who got to full oral feeding, and then 3 patients who are still partially tube fed.
Okay. So lessons learned, everything is so individualized for each infant, the feeding plan, the developmental plan, follow-up. That is one of the biggest lessons we've learned. There's complexity and nuance with each patient path. Time to full oral feeds varies widely. We don't see G-tube as a failure. We see it as a way to support our children as they are advancing, hopefully, to full oral feeds. There is a significant impact when you see other comorbidities, and something that we're unfortunately seeing a lot of in the States right now is in utero exposure to fentanyl, which causes not only some of the things you see in Robian sequence, but significant neurodevelopmental dysregulation, and it's just really hard. These kiddos take a lot more support. Family dynamics, involvement goals, access barriers to care. I kind of talked about that on my last slide. And then again, we serve such a wide area, and families come to us from all over the state of Washington, Alaska, Montana, Idaho, and sometimes even Oregon. And so we have to think about and adjust our strategies if we have a patient and family that's from far away, because we obviously don't want to ask someone to come drive 5 hours every week or 2 weeks. And so these are all the things that we're learning and trying to improve on. Thank you.
Thank you.
Yes, we're going to dedicate the last minutes to questions, because
Yes, sure.
I had a presentation about our friend's experience, but it was asking questions more than answering to it. So it was interesting. I think that we are beginning a bit too early and too hard. Babies can do it, so.
But I'm still surprised that despite all this input, you have much more professional input than we have in Germany. In our center, 80% of babies, at least 80%, go home fully orally fed without a feeding tube. And that's after a mean duration of 17 days. And we perhaps don't think enough about it, but the success speaks for itself. But do we see the minor patients, or I don't understand it?
What is do all of the babies go home from that they're fully eating by now, or from not?
Good point.
How long?
Do you discharge on a feeding tube or without feeding tube?
It depends.
And what's the proportion?
2/3 with
feeding tube, okay.
All the isolated robin, they go home without nasogastric tube. When they're syndromic, it depends. It depends.
Because the syndromic are so diverse, you can't really put them into one kettle. So that's why I focused on the isolated ones. And they are all basically able to swallow. I mean, if you have a Möbius sequence, you can't expect them to swallow. to be fed without the tube. But if it's isolated, as I said, I would say 85% similar experience. Okay, that's reassuring.
But again, we have home care, very high level of home care, so they are going home very early with the tube. It's nothing for us to discharge home with the tube. So we prefer to guarantee the growth and not to have problems in the first weeks of life. So
I think also, Christian, we're meeting them for the first time sometimes at 4 weeks, starting maybe the therapy at 5 weeks, and then 75% are.
Why so late?
Yeah.
Why?
Yeah, they're coming to it late. They're from the whole geographic region. And
We'd love to get them.
75% have an associated syndrome, so in our population, I think it's different.
And why are you pushing the issue of feeding them the prone position so much? Because you never feed prone position.
We don't feed prone.
But you advocated prone positioning for some reason. I don't know.
No, not feeding. Just for development. Like tummy time.
I thought about feeding. That didn't make sense to me. But then it's always good to ask.
Veronique, what is different in Necker? What are your tips that you have learned about eating?
with TPP, we have all to learn. So I think that maybe we are trying too early, and the movement created by the sucking, either with the pacifier or with the nipple, is too hard for the girls at the beginning. So, but I would say that
I found one trick which helped. The part of the plate between the two wires, I make it nanometric, very, very, very thin, so I have more space for the nipple, and I found it quite useful.
What do you mean? Would you make it thinner? Where do you make it thinner?
On the plate between the two wires, I make it very thin, so it looks like this. I made the plate really nanometric. It's
the anterior part of the plate.
Yeah,
like the wall
or
like the plate.
no, you have the gum, the plate, and this part here. I make it
You have to be really careful with like reducing the thickness because
but just in the middle.
for a second, show us.
Just in the middle.
Yes.
Here, just here. On the green part, I make it far more thinner than this. So there's far more place for the nipple. And here, I leave it with a good space.
I don't think that's something that we are doing, for example, because I know that sure there are some places, and mostly maybe Connie also knows about it, some places that they are being grinded, but I don't think the thickness matters so much. And also we have seen sometimes where the plate has been grinded out too much. So in a certain moment you're losing hold, so you need to be a bit careful. And the thickness is a problem for safety again.
But if you keep the space under the wire quite thick, actually, honestly, for the moment it is broken.
I'm just
But
talking
for
about
the
our
nipple, it's incredible, and the wire is quite large too.
But the pressure marks can appear in some other areas, not only in the front.
But Marty, different experience, different settings. Don't worry.
Yeah, totally. But I'm just saying that the pressure marks don't only appear in the front, but also sometimes a lot in the posterior side, and that's why, for example, we do this wing shape in the base plate.
Of course, you shouldn't do it very thin everywhere, and especially not under the wires, because it's on the space where you need a thickness.
Don't go below the top.
Over the place. But on here, when you have the wires mechanically, there's the vessels.
That sounds like it went out. Okay, the nipple end. I struggle with that quite a bit. Okay.
And then I take nipples. I take the milling machine and all the plastic around the nipple. I just take it off, so the nipple can go in the mouth without being disturbing by the wire. Well, I'll take it. Very well.
I know, I might have to use some of your.
And that's what such workshops are all about. Getting you to think about what you are doing. Think about whether you can improve your own approach.